Afternoon, everyone. I really thank everyone here for inviting me as a speaker. So in contrast to the other two speakers that we've just heard, I have been doing teledermatology more at scale just since the COVID-19 pandemic. So hopefully can give you a little bit different perspective. Certainly have learned from, just our veterans from, KP and VA to launch sort of things at Duke. But there's some important differences in reimbursement in the United States, in sort of a system like a Veterans Affair where access is really important and reimbursement really doesn't dictate, how teledermatology happens, and in a capitated system. We're very much a fee-for-service system at Duke, and so that has faced some challenges. So hopefully I can kind of go over some of those. So we had a huge access problem at Duke University for dermatology access. Just nationally in the US, there's not enough dermatologists to take care of dermatology demand. We also have a huge demand due to an aging population. We estimate by 2030, about a fifth of the population will be, over 65 years of age or Medicare population that generally needs more care. We also have difficulty reaching patients with medically, disadvantaged backgrounds. And then longer wait times just brings that anxious patient, where the quality of life significantly suffers. So at Duke in September 2021, an estimated wait time between a Duke primary care clinic referral and initial Duke dermatology visit for a concern of a skin cancer was 97 days. So this is not an average patient calling Duke. This is a primary care provider who's already seen a patient, wanting a patient to come and be seen for a biopsy, and it was almost taking 100 days for that patient to come in. So this doesn't look good from a payer standpoint. This doesn't look good at a university standpoint, going to different payers because access is really poor. And then teledermatology in the U.S., started back in 1994. There's a lot of progress made through the VA system and the Kaiser Permanente and other systems. However, in 2020, 96.9% of the surveyed AAD members, had started using teledermatology when the pandemic started. So started to see this growth of use of teledermatology, as you've heard from other speakers. So we did this, a study. We looked at it within Duke on also in this registry data called AAD DataDerm. So this American Academy of Dermatology DataDerm, and essentially a private practice database where this kind of shows, I apologize for the small text, but it sort of shows you the trends of teledermatology usage. And I will tell you that, as a percentage of total visits in 2020, it went down from 2.9% to 2021 to 0.3%. So as clinics started to open up, people went back to face-to-face. And so we saw the similar trend within Duke as well. But what was interesting was, there's a couple of upsloping trends. One, patients that are under the age of 40, which is sort of like to the left side, the bottom graph, you can see slight uptick. So younger patients are preferring, virtual care. And then utilization by non-Caucasian patients, kind of kept up a little bit more compared to the Caucasian patients. So we think there may be some, some advantages to teledermatology to, traditionally marginalized groups. So we do think teledermatology is something that needs to continue. But to be able to do that at Duke in a fee-for-service model had a lot of challenges. So I call them these rots of teledermatology. We had zero interest in doing teledermatology when I first got to Duke about 5 years ago. And there's some challenges, so reimbursement is a huge challenge, but with the pandemic, there was equal reimbursement to in-person visits to telederm, so that helped a lot. We have operational barriers. You would log into a video and the patient's fumbling around with the Zoom link, or they don't know they had a video visit and things like that. So we figured we needed infrastructure to physically kind of room the patients or somebody that can help with the tech issues as this was happening, especially for synchronous care. And then the other issue is that, when you're working in a fee-for-service model, you have to control the overhead because the revenue turns out to be about half of in-person visits with telederm. So the only way that becomes operational is if you reduce it and do this in a very, very limited overhead structure. The technology, certainly the video quality with Zoom improved significantly during Zoom. And then finally, the stakeholder buy-in. So operational readiness, as Dr. O mentioned, is something that we didn't look at it strategically through an operational framework, but having patients, dermatologists, and referring providers buy into this, we thought would help a lot. So how do we handle that with our system? So as you mentioned, the solutions were the reimbursement was actually a huge driver. For operationalization, we utilized economies at scale. So what happened was we kind of launched a virtual care clinic, which was a collection of nurses and CMAs that were trained in rooming patients with tech issues. So not some IT person sitting somewhere else in the world, guiding these patients, but real healthcare professionals asking the relevant questions of the history, helping patients log into their Zoom clinics and things like that. And instead of just these, serving the Department of Dermatology, they were serving, endocrine or gastroenterology. And so when they weren't doing dermatology clinics, they were doing other things. So essentially the cost became significantly lower to each department. And again, I apologize for the small text, but one thing that we were able to do, with some of this infrastructure in place is to triage, patients into the video visits, but also be able to decide, okay, well, this person, we had a video visit, but now instead of bringing them in person, we can have them follow up with the teledermatology staff to make sure they're doing better down the road. So reducing subsequent visits. As far as the technology, as you've heard with multiple speakers before, video quality is really not that great, but actual interaction quality with Zoom became more stabilized. But we still needed still images. So in a fee-for-service model, the store and forward images really don't reimburse a whole lot. And so what we did was we used the store and forward technology to get the images, but then we would transfer all those, what we call these e-communication with images into video visits. And then the stakeholder buy-in, fortunately at a university, kind of have like a primary care base of physicians. And then we, engaged our, about, I want to say almost 50% of our dermatology workforce to deliver some kind of dermatology care. So, all right, so this is another workflow diagram, and I know it's really complicated, but starting on the left side is our store and forward workflow. This is a natural inbuilt workflow through our Epic electronic medical record system. We had a lesion, questionnaire and a rash questionnaire that were separate, evaluated by, different providers. And then all of those, we tried as many of those to convert them into video visits. So essentially, getting this information, this is happening from a peer-to-peer. So a primary care physician is filling out these forms when there's a patient that's in their clinic. But instead of giving them recommendations, what we're doing is basically contacting those patients and putting them in a video encounter. So this really helps drive the reimbursement up to a level where we can sustain the system, and gives us those store and forward, still images that are good quality. And then when patients are scheduled on the video visit, and if you go to the right side of the flow chart, there's three possibilities. Either you're going to get technical difficulties and you're not going to be able to be successful, and that's actually very low. So it's less than 2% in our system because of a lot of the virtual care clinic staff competence. And then there's, patients are generally essentially stratified into two forms. There's low risk patients like seborrheic dermatitis or acne, something that the primary care physician can follow up, and then they don't need to come back and see dermatology. So we do not allow those patients to schedule back into dermatology. They have to go back through their primary care to go through this process. And then there's these high complexity patients that come in. And for those, either we, reserve these acute care visit slots or urgent care slots, so really improving their flow into Duke dermatology, or they need, even inpatient hospitalization. We've done that for a tertiary syphilis patient, for example. And then there's ones where we can just do, give dermatology care, but then follow up with the nurse to figure out if they're doing better. So it really helps us basically triage and reserve our inpatient slots for really either high risk patients or patients that really need to be seen sooner. However, there are issues with this system. We have to reduce the tech issues, which hopefully the virtual care clinic really helped with that. We do have to figure out how to reduce the number of lower risk patients to be seen in dermatology, which comes from empowering our primary care providers, and then triaging the right patient to the right provider. So a complex patient that has a blistering disorder, for example, their first in-person visit will be with a specialist in blistering disease and not so much just any dermatology provider. However, what we were seeing was a huge drop-off in the number of e-communication orders and the patients that were scheduling video visits. So, for example, there would be a lot of lesion e-communication orders with lots of images, but not all those patients were scheduling video visits. So then comes this ethical issue where what if something was a melanoma and the patient was not scheduled into video? And how can we review all these orders without reimbursement? And that's a very real, ethical issue. Where do we draw the line? And the second issue was, as we've heard before, image quality. So if poor quality images were coming in, then how do we deal with this at scale when we've got 57 practices, primary care practices referring 20 to 25 referrals a day? So hence, now we brought you up to finally the crux of this talk. So, there's a couple of things. One, from a diagnostic issue, when we have these images at scale for especially lesions or high risk issues like melanoma, these lesion classification algorithms are really, really helpful. And there's a multitude of those out there. This is one that we developed at Duke that compared really well to our dermatologists. And here in this particular paper, we also looked at clinical data because we wanted to know if an image was sufficient, or clinical data like a patient being a smoker or Caucasian or taking certain medications would make a difference. And the conclusion of this paper was that the images were actually just as good as images plus clinical model. So we didn't really actually see a huge difference in a better accuracy with adding clinical data. So we feel pretty confident that if a good image classification model that could risk stratify lesions, then we would hopefully not miss a melanoma coming through, even if we were not getting reimbursed for it. This is a low cost model to make sure that all of our patients are getting good healthcare without increasing any provider burden to look through all the images. The other thing is, image quality. So the second issue at scale is, getting poor quality images. So usually we kind of follow the VA model where the primary care physicians are taking like a forest view and a close-up view. But if they don't take dermoscopy or the images are blurry, that becomes an issue. So we wanted to look at that much more systematically in terms of this workflow. And it's coming into focus where we have this e-com structure on the left side. So these are, again, the store-and-forward images where we're looking at image quality. So we kind of looked through our first year of launch, which was essentially half of 2020 into 2021, and there were 419 images submitted. Before the primary care physicians launch, their site launches, we have this 20-minute learning module where they watch this video just once to improve the image quality. They take a quiz and they rate their satisfaction with the module. The adoption rate was 89%. So we don't force them to take this module, but 89% of the primary care physicians at the relevant sites did review this module. Also teaches them how to take dermoscopy and how to attach the dermatoscope, etc. So some practical tips. And so this data, is September 2021 to July 2022. And then when we look at the image metrics, 19% unsatisfactory images were submitted by those who had completed the module, but those who had not submitted 50% unsatisfactory images. So that it kind of goes to show you it's really important to train primary care physicians and subsequently extrapolating to patients to take good images. And so this is just sort of an odds ratio analysis that shows that the high quality images, the LMS module, the learning module increased higher quality images by 4-fold. However, when you look at low quality images, 22% were still unsatisfactory, in the ones that had taken the module. So even though we improved the image quality, there's still a huge issue if you're looking at 30,000 images a year or 300,000 images a year, as we have heard from the veterans. In this field who've been doing this for 10 years. If we're getting 300,000 images and a quarter of them are not good quality, this raises a huge issue and increased burden on the staff and providers to request good quality images. So this led us to propose another project that we did looking at an image quality analysis module, which is an AI-based approach, so deep learning-based approach. And these are some of the metrics that I wanted to share with you. So at a threshold of 0.62, and we set the PPV at actually 0.9. That's the threshold that we chose. And the reason, so we had the AUC of 0.885, sensitivity of 0.83, specificity of 7.8. And the reason we kind of sacrificed the NPV, or the negative predictive value, is we figured that if the patients have to take extra images, at a high PPV, essentially the model is going to call some good quality images bad quality. So the patients and the providers are going to have to take more images. So it's, even though they took a good quality images, sometimes they might have to take more, but that's not a detriment. So we artificially set the the threshold for PPV really high, sacrificing a little bit on the NPV, but essentially creating a filter that bad quality images are reduced significantly. And then we validated with two sets. These are both retrospective validations, unfortunately, but they were patient-derived images directly. And then we also looked at the primary care derived images. So in the primary care set, certainly the quality was improved. The metrics looked a little bit better. But even in the patient-derived images, the model performed really, really well. And so the idea is that, from a 22% poor quality, hopefully we can decrease it to, less than 10%, or hopefully even 5% in the future. And so I also wanted to search and see if there's other people in the world who are looking at image quality. Today, listening to other speakers, I'm confident that this is the right direction. There's also our colleagues over in Stanford that have a similar idea and had a deep learning based model, and they have translated into a true image app. If anyone is interested in using that, so they're a little bit ahead in that avenue. And so this app can reject up to 50% of subpar images while retaining 80% good quality images. It's a little bit hard to compare two models because the methodologies were different, and of course they were developed on different data sets. But it is important to highlight that both, I think, can handle lesion and rash images. And the idea is that, something like this implemented into the system can really reduce poor quality images and burden. So some of the issues that we see with these apps is, how do you integrate that into your EHR? How do you make sure the images are transferred securely? Does the True Image app, have all the security features that are required by academic institutions? And then how do you get point of care, quick turnaround from the model output? And then where's the real world use validation? Some of these things that we want to be working on in the future. So the transfer of sensitive images, just how do you reduce that model host server time, and the real world validation are really important to consider in the future. But we also see a lot of potential, not just in image quality, but in lesion analysis, but also rashes and quantification of rashes. In teledermatology, it's very challenging to be able to say, hey, is your eczema getting better? Unless it's clear completely. How do you tell if it's 10% down from 30% before? And so we think that there are ways where if patients were to upload, a lot of the images, we can kind of back into these, validated models. Like, for example, melasma. Since we are in Singapore and a lot of skin of color around us, the MMCI is a very nice validated score. So if patients were to submit, facial images, if you had an algorithm that could quantify melasma, you could actually see, interventions making this better or worse. Two things we need to understand: how you standardize image taking process, layer image quality on top, and then some kind of a methodology to have an AI output back into the MMCI score, something that we're developing with a private company called Skintelligent. And similarly with vitiligo. But there are lots of other opportunities. As you can see, a lot of clinical scales that can be utilized. And all of these conditions, as Dr. Tejasvi mentioned before, can potentially be handled through teledermatology in a very, very, scientific and, easy format, reserving the space for in-person appointments for those who cannot, for those patients who cannot be tackled through teledermatology. So with that, I won't take any more of your time. Certainly want to thank a lot of the folks over at Duke and a lot of special people that were mentoring and guiding to me through these projects. And thanks again for ISTD for inviting me. And I'll take, I guess we go into discussion at this point.
Probably not. Thank you.